All right, good evening, everyone, and thank you for joining us for tonight's Woo You event. Tonight we have Dr. Justin Schweitzer, and he's going to be talking on cutting edge cataract care cases and considerations. I'll be your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to RX Site for providing an educational grant for this event tonight. This will be worth 1 hour of CE credit, so please be sure to attend for a minimum of 50 minutes. We will have CE certificates sent to you via email and to Arbo with your OE tracker numbers. If you could fill out the survey that will be in the chat feature, and it'll also be there when the webinar ends. Those CE certificates will be emailed to you within about 4 weeks. But we will have a QR code at the end of tonight's event so you can use your OE tracker and get your credit sooner. We'll save questions towards the end. You can just ask it in the Q&A or the chat. And then if you're on your phone, you can find the Q&A at the top or the chat feature under the three dots under more. All right, so I'm excited to introduce our speaker for tonight. Dr. Justin Schweitzer specializes in advanced glaucoma, refractive surgical clinical care, and anterior segment pathology at Vance Thompson Vision. He received his professional training and Doctor of Optometry degree at Pacific. And in 2012, he pursued his dream to focus on glaucoma, advanced anterior segment surgery care, and pathology in joining Vance Thompson Vision and earned a fellowship in the American Academy of Optometry in 2013. And he is the optometric externship director at Vance Thomas Vision. Dr. Schweitzer regularly lectures on glaucoma, anterior segment pathology, refractive surgical care, and surgical management at state, regional, and national meetings. He is currently the chief medical editor of Modern Optometry and has contributed to book chapters, journal articles, and case studies in peer-reviewed and non-peer-reviewed journals. He's an advocate of an integrated eye care delivery model and is currently serving as a board member for the South Dakota Optometric Society. He's also the board member of the Optometric Glaucoma Society, a member of the American Optometric Association, the Optometric Cornea Cataract and Refractive Surgery, Scleral Lens Education Society, Intrepid, and is actively involved in his community eye care initiatives. So, like, when do you sleep? Because you also have three children or
Two
kiddos?
children. Yep.
Two kiddos. Yeah.
You bet.
Wow. All right. We all need your energy.
You have it.
Oh, awesome. Here are his financial disclosures, and I'll have you take it from here. Thank you so much.
Thank you so much for the kind introduction, and always a pleasure to be here at Wu University and have the opportunity to be able to be a part of it. Excited to spend the next 50 minutes with everyone. Thank you all for taking time tonight away from family, friends, and significant others to spend it with me. We're really going to focus tonight on talking a little bit about cataract surgery and really focused more on the optometric or the OD's role in managing these types of patients. And I know everyone on the call tonight is very, very likely seeing cataract patients either preoperatively, preparing them for cataract surgery, as well as postoperatively. And these patients can be at times very frustrating to manage and deal with, and at times a very fulfilling thing to do when you're managing these types of patients. And my goal tonight over the next 50 minutes is really to talk about some of the new technologies in cataract surgery care, really talk about some of the psychology around how do we manage these patients after maybe they've had a more advanced intraocular implant and maybe on paper in our exam, they're doing really, really well, but they're in front of you telling you that they're not doing well. How do we manage these types of patients with these higher expectations at times? Introduce you to some of these new IOL technologies. And then I have some cases kind of spread out towards the end, basic post-operative types of situations that for a lot of you will probably be review, but hopefully for some of you, just something that you could take back to hopefully manage your patients better. We'll also spend a fair amount of time talking about what is traditional cataract surgery versus this more advanced type of cataract surgery. And I will tell you right now that cataract surgery really has changed. It's not just rehabilitative surgery anymore. It's really turned into refractive surgery. And the reason that's happened is really because of the new technologies that have come out over the last decade or so. I'm in a practice that is really focused on managing patients with cataracts and interested in educating. I don't look at myself as a salesman for technology, but I really feel like it's very important to educate my patients on what their options are. And a lot of these patients, when they come into our practice, they're not always interested in one of those advanced IOL technologies, but they still need to know about them. And so I take time to educate them on a variety of different options. 60% of our patients, 65% of our patients that come into the clinic that I work at choose to do a monofocal technology and continue to wear glasses or contact lenses, and hopefully are very, very happy that way. 30 to 35% of my patients choose to do a more advanced intraocular implant, whether that be an extended depth of focus, a multifocal, a light adjustable lens. That's about 30 to 35%. And they'd like to reduce some of their dependence on their glasses. And so that kind of gives you a breakdown in the practice that I'm at. I'm in a tertiary care practice. And so all the patients that I'm seeing are really referred in from friends, colleagues in the community. I get them ready for their cataract surgery procedure. And then the surgeon that I work with performs that surgery. And many of those patients go back into those optometrist chairs. And they're the ones that do have to at times manage some of the tough psychological things that comes with these implants or complications. We hope they're minimal, and the majority of the time they are minimal. The beauty of cataract surgery, it is the safest surgery that's done in the United States. But I think our job as the optometrist is probably more difficult at times than the surgery, because we're dealing with things preoperatively, we're dealing with some of the things postoperatively, and kind of taking these patients on this journey, which is where I want to go now. Where does the cataract journey really start? And it starts with all of you. It starts with optometrists. When that patient is in your clinical chair, you've known them for years and years. You may have corrected them with glasses, contact lenses for years and years, but now all of a sudden you've identified that they have a cataract. They're not seeing as well. Where do we go from there? So just some basic review things. Obviously, with slit lamp exam, we want to take a close look at certain things like the lids, the cornea, the lens, the vitreous, to be able to make a proper recommendation. We obviously don't want to recommend doing an advanced implant, like a multifocal type of implant, if we're seeing EBMD that's in the central part of their vision, like this particular patient. This may be a patient we say, hey, we need to manage your surface first. Let's get the dry under control. But we also may need to do an SK or a PTK, phototherapeutic keratectomy, to smooth that surface out first before you undergo cataract surgery. So educating them properly. We also don't want to miss things like Fuchs dystrophy, looking closely at the posterior part of the cornea. Probably the number one thing that I see in our clinic that's missed by doctors and by residents and externs is very early or even more advanced Fuchs dystrophy. And it's an easy thing to miss, because if you don't crank your slit lamp up a bit and really are looking for those guttata, it can be overlooked. And this can be a frustrating thing for patients. And we don't want to put some of these advanced technologies in the eye if we overlook these types of things. So a very thorough slit lamp exam to identify these types of things. And then probably the most crucial thing that we as optometrists have to do and manage before we send a patient in for cataract surgery, and that is really to manage the ocular surface. The technologies that we have on the market today, whether it be multifocal technologies, extended depth of focus technologies, even a monofocal technology, a monofocal plus technology, in my opinion, they all work extremely well. I have tons of happy patients. A lot of our colleagues have tons of happy patients. But the patients that are usually most disappointed are eyes that the technology never should have been put into. And those would be eyes that have, a lot of times, ocular surface disease. And we need to be looking for this and managing it before these patients undergo cataract surgery. Sometimes we think of dry and it gets a little bit complicated. There's a lot of different things we can include in our offices, whether it be, advanced technology, but initially keep it simple. We all have slit lamps. You need a slit lamp. It's an important piece to manage dry eye. A questionnaire. That's the second thing. It drives the conversation around, are they symptomatic or not? It allows your technicians to let you know if there's dry eye present. Another very inexpensive thing that could give you a ton of information are your vital dyes. You're looking for staining. Staining equals inflammation. You're looking for tear meniscus height. You're looking for lissamine staining on the conjunctiva, which can point to certain types of autoimmune conditions. You can get tear breakup time. So much can be learned with this inexpensive dye that we put into the eye. And then you need a digit, one finger to be able to press on the glands, to be able to look at what kind of gland substance come out? What does the meibum look like? Is it thick? Is it viscous? Or is it something that looks very clear like olive oil? So very simple, four things to consider when you're trying to get that patient prepared for cataract surgery, identifying ocular surface disease. Other things that you can add to your arsenal, though, is you want to add more technology. To me, the number one thing being osmolarity. I put a study down below there, or a graph out of a study showing that osmolarity, out of all the different dry eye tests on the market, the one that is most positive predictive for dry eye, 87% of the time, if you have an abnormal osmolarity, it's dry eye. And that's why, to me, that's my most important point of care test. If you're going to invest in any type of point of care test, I would lean towards investing in osmolarity. These four things, extremely important. You're all going to have a slit lamp. Questionnaire, simple, inexpensive. Vital dyes, simple, inexpensive. And as long as you have one finger, you're going to be able to press on the glands. If you're going to invest in technology, to me, osmolarity would be the next thing. Then you have some other technologies out there. On the right, a technology that I actually use where I can get non-invasive tear breakup time. I can look at their eye blink. I can look at their lipid layer thickness, their tear meniscus height, and I can look at their glands with meibography. My team can get this in 2 to 3 minutes. I have this in front of me to educate the patient, but also to dictate the plan that I'm going to put in place to manage their ocular surface disease before we move forward with cataract surgery and some of these really nice intraocular lenses. So, dry eye piece of things, crucial for these technologies and really in optometry's wheelhouse. We're the ones that need to manage this. Don't send it to a surgeon for cataract surgery until you've done the work with the ocular surface to get it prepared for success on the backside. It'll save you a ton of time on the backside after the surgery. We know it's prevalent. There's multiple studies showing this. So this was one study looking at ocular surface dysfunction in patients that were presenting for cataract surgery. They looked at a variety of different types of tests. They looked at corneal staining. They looked at MMP9, which is inflammation. They looked at osmolarity. And really what they found is that 80% of the 120 patients that presented for cataract surgery in this particular study had at least one abnormal tear test. It needs to be managed. This is a phaco study. This is another study done by Dr. Bill Trattler. What they looked at, these patients were presenting for cataract surgery. 50% of these patients had central corneal staining. 74% of these patients had, or 75% of these patients or so, had some staining on the cornea. So a high percentage of patients presenting with corneal staining typically equal in inflammation when we're talking about ocular surface disease or dry eye. Again, just kind of beating you over the head that this is prevalent and we just have to manage it before we send these patients in. Continuing with the journey, what are our jobs? We need to make sure the retina is okay. So you think of a patient like this that has a pretty significant epiretinal membrane. I am not going to advise this patient to have any type of advanced intraocular lens. They won't be a good candidate for a diffractive lens like a multifocal. I would maybe consider a light adjustable lens just because it's more of a monofocal lens, but I still would be careful because patients are going to have to pay for that technology and the visual outcome may be not ideal when you see this type of thing. So taking a close look at the retina, the macula, looking for things like glaucoma to talk to our patients about the different types of implants that they can choose from. And then when we think about when they get to the surgeon, what are the things that are occurring? Well, there's a lot of things that are going to happen at the surgical center. There's going to be biometric readings that are taken, a variety of different topographies that are going to be done. There's even intraoperative aberrometry where the surgeon will remove the cataract in a phakic situation in the operating room. They use this instrument over the top of the eye to be able to properly choose the right power of the IOL. For us as optometrists, I think the key thing before sending again in preoperative, what should we be talking about, are really their Ks. You know, all of us have some way to measure Ks of the cornea, whether it be a pentacam, whether it be NIDIC, OPD, whether it be manual Ks, whether it be auto Ks. And we all know, and it's important to know, that that corneal astigmatism is the real key thing to talk to these patients about. If a patient has 0.75 diopters of corneal astigmatism or more, I already start talking to them about the fact that, hey, we may want to think about a technology that corrects your astigmatism. If it's less than that, we probably will sneak by without having to worry about doing that. But 0.75 diopters or above of corneal astigmatism, we should at least be mentioning that the surgical center will likely be talking to you about ways to correct that astigmatism as well, just like we would with a pair of contact lenses. Getting into goals, I always ask my patients a very simple question when they walk into the door, and it's really, do you mind wearing glasses? Or do you want to wear glasses after surgery? This kind of drives the conversation for me, and I always try to make recommendations for my patients as well based on their ocular health, based on what their goals are. If they're a patient that says to me, I love wearing glasses. I'd like to keep wearing glasses. I'm a farmer here in South Dakota and I want the protection. Or it's a 80-year-old patient that says, boy, I don't want anyone to see these wrinkles or these bags underneath my eye. I'm not going to argue with them. Some people just want to be able to continue to wear glasses or contact lenses. And as I mentioned earlier, that's about 60 to 65% of my patients. But I try to keep it simple up front. If they say, boy, I'd like to think about getting out of these, that drives the conversation in a little bit different direction. And we still educate and talk about all the options, but now I have in my mind that they're more interested in maybe reducing some of their dependence on their glasses. I also think a key thing that I always mention to patients is I never promise them that any technology we have, and we're going to talk about all the technology tonight, will get you completely 100% out of glasses. There's no such technology on planet Earth right now that can do that. Now, we have technology that can get you 90% of the way there, 85% of the way there, but there's not a technology that can get you 100% of the way there. They probably will need small pair of reading glasses at time to pick up tiny print or tiny fishing lure, sewing, knitting, even multifocal technology, which is amazing, still is not 100% glasses free situation. And I think that's a really important point to bring up to your patients as well. Like me, many of you are probably seeing younger patients that are asking to be referred for cataract surgery. We see younger and younger patients all the time because they're talking to friends, they're talking to, colleagues and other people in their lives that are having great outcomes with different technologies. And these patients need to be educated that their natural lens is probably still functional. We have to remember that a 55-year-old patient, although has advanced presbyopia, that lens is stiffened a lot, but they still have some capability of focusing ability. And so you want to be careful if you recommend, for example, a monofocal lens. We know we're going to take them to an absolute presbyopic state. They're not going to be able to see up close really whatsoever. Much different than that 55-year-old lens. So making sure we're educating the difference between that natural lens and even a multifocal where you don't have that natural progression all the time. They're going to have spots in their vision that they have to get used to and get comfortable with. It's not like when they were 35 and 40 when they had that nice progressive situation. And then just the combination of IOLs, we'll get into that here in a little bit. I also think it's important to keep in mind, and this is review, where they are when they walk into your clinic. Your unhappiest patient would be a myope that's a minus 250 that loves to take their glasses off to read. And they come into our surgical center and we target them for distance with a monofocal lens. And boy, they're 2015, 2020 far away. But guess what we just did? We removed that beautiful up close vision for them and they are unhappy. Hyperopic patient, hyperopic patients, great candidates for multifocal technology. Why? Because probably around the age of 40, 41, they haven't seen good at distance or near. Even younger, if it's a high hyperope, they haven't seen good at distance or near for an extended period of time. And so I try to keep those things in mind and I try to educate around that as well. And these are those refractive considerations. Is it a patient that is comfortable with some monovision? Do they need a near point target or would they prefer a distant target? These are all things that you'll have discussions with before you send them to the surgeon. And then I would encourage you to then communicate with that surgical center and say, this is a patient that I think would be ideal for a near point target. They have no problem wearing glasses at distance. They really want to be able to take their glasses off in bed and be able to read up close. Or, hey, this is a patient for the last, 20 years, 25 years, 30 years that I've had in some monovision correction. It may be a good idea to consider monovision with this patient because they've been very happy with that type of technology that I provided them. And so what you say a lot of times in these referrals to the surgeons you work with can be very powerful. So next, I want to just take some time to kind of review the implant options. And I'm really going to more or less review this as a category I'm going to pick out a couple implants to talk about just because they're newer and I think it's important to discuss them. But implant category to me is more important. So we'll touch on that as we go through this section right now. So monofocal lenses, I have a list here for you. There's a ton of them out there. And this is really going to be surgeon preference. One unique one in here that we're going to pull out and talk about next would be the light adjustable type of lens. You'll see that kind of in the middle area there. But these are all considered monofocal implants or traditional lenses, in my opinion, except for probably the light adjustable lens. These lenses typically are lenses that are covered by insurance. Light adjustable typically is a lens that surgeons are charging cost for. It's not a traditional monofocal implant, and so there's usually cost behind that one. But a lot of the other ones are your traditional monofocal implants that insurance will be involved with. And these would be implants where I'm comfortable telling a patient we can target you either for near or we can target you for far, but you're still likely going to need to wear glasses depending on how much astigmatism you have on the cornea or where your near point demand is, or how good do you want to see far away. And so for me, when I have a conversation about monofocal technology minus the light adjustable lens, we'll get to that in a second. Monofocal technology, it's you got to be pretty comfortable with wearing glasses or contact lenses. We can still steer it in one direction, but you have to be comfortable most likely with wearing glasses or contact lenses. Let's talk about the light adjustable lens and what makes it special. And so this is a technology that I will say right away, there's got to be a commitment from the practice that is doing this. Logistically, there's more work with this lens, but it is a very precise lens that can provide really excellent distance vision for patients. And so remove that distance need for glasses or contact lenses. This lens also does a very nice job of providing some intermediate vision, computer length, dashboard on a vehicle type of vision. And so it does have a little bit of an EDOF property, and I'll explain that here in a little bit. I tell patients this isn't your near workhorse type of lens. You very likely are going to need glasses for up close work with this lens. We can try to offset it a little bit to try to give you some near, but I very likely do not promise that for patients. It's a workhorse distance lens, great lens for post-refractive patients, and you'll see why here in a little bit, but not a lens that's going to provide a ton of near. So what's unique about it is it has these regular silicone polymers, and within there, there's also these mobile silicone subunits, and these are photosensitive macromers. And so this lens, after it's implanted, is able to be adjusted, and we can adjust it 3 times. And then there's this lock-in phase, and that's what we'll touch on next is how does it work? Well, it's just like standard cataract surgery initially. The patient comes in, they have traditional cataract surgery. They see you for the day 1 visit, they see you for the week 1 visit, and then at about a month is when the work starts. This is where we get a nice prescription. We find out, all right, what's the residual refractive error? Maybe they're a patient that had a diopter of corneal cylinder. This lens, being a monofocal lens, initially is not going to correct the astigmatism. We need to correct the astigmatism with the light delivery system. Maybe they have 2 diopters of astigmatism. The point is, initially, there may be some hand-holding for that first 30 days. So that residual refractive error is determined. After that residual refractive error is determined, the patient is dilated. Typically, we like to see a dilation of 7 millimeters of the pupil or more. And then they're placed in the light delivery device system. The refraction is plugged in. And then what our goal is, do we target both eyes for plano? Are we offsetting a little bit? Plano minus 50, depending on what the goal is for that patient and the delivery system is delivered. And the radius of curvature, the curvature of that lens will change depending on what we're trying to induce. You can do that up to 3 times. Typically, these patients are brought back every other day. Usually what I like to do is bring them back weekly to make those adjustments. I like for my patients to be able to test out their vision. We make an adjustment, go out into the real world, see what you think. Do you like the way that you're seeing? If they don't like the way that they're seeing, we can do a second adjustment based on what they give me from a feedback standpoint. We can even do a third adjustment based on what that feedback is. And then there's really this lock-in phase. So you have 2 lock-ins at the end. So in total, about 5 treatments to get this lens to the spot that you want it to be. This is just a short video just to kind of show you guys the process and the way that it works. So this is the screen that you see when you're doing the adjustment as the doctor. You can see we have a nice dilated pupil here. I'm really just focusing on the haptics of the implant. There's the system. My patient, I am using a small mirror, looks like a gonio mirror essentially, and it's allowing me to focus on those haptics very clearly. It's allowing the light to be delivered to the implant specifically. Each one of these treatments is a little bit different. Sometimes it's a 2-minute treatment. Sometimes it's a 60-second treatment. I'm just depressing a pedal right now, and I'm delivering that light to the implant to change that radius of curvature. And so again, you can see with this patient that I think the treatment was it was about 45 seconds, as I recall, to treat that particular situation. And then the patient leaves for a week, and I'll see him back for a follow-up. The accuracy of this lens from the FDA results impressive. 92% of patients were in a half diopter of target of their manifest refractive spherical equivalent. The results showed that 100% of these eyes had best corrected visual acuity of 20 or 40 or better. My experience doing a lot of these, it's a very impressive distance lens, very impressive intermediate lens. They have two different types of lenses that are now on the market. They have the light adjustable lens, and then there's also a lens called the light adjustable lens plus, or LAO plus, which has a little bit of an EDOF concept to it. I will say my experience has been that I can induce a little bit of spherical aberration to make near a little bit better for these patients, because quite often these patients settle a little bit on the plus side when they come to see you. So you're doing the refraction. A lot of times you're getting a plus 50, plus 75. And when you do the treatment, you're bringing them back to plano, or you're even taking them a little minus if you want to give them some near. And by doing that, you're inducing some spherical aberration, which is allowing some of that kind of EDOF effect to occur. And that's really why when I call it a monofocal lens, it's a monofocal lens, but it does do a little bit better with distance and then some of that intermediate as well. Toric lenses, not going away. Plenty of these on the market. I mentioned earlier, if you have a patient with a K value of 0.75 or above, I'd be talking about these lenses so that the patient is aware that they have options to correct their astigmatism. The problem with toric lenses really is residual astigmatism. And this can come from a variety of things. This can come because the lens is rotated post-surgery. It can happen because it's placed in the wrong eye. There's a variety of different reasons that this can occur. How do we correct this? Well, at times it's you rotate it back, and we'll talk about that here in a second. Sometimes it's a laser fine tune. Sometimes it's LRIs, limbo relaxant incisions, or you fix it with glasses or contact lenses. These would be the reason for residual astigmatism. For us as optometrists, you move over to the right side. We want to prevent the wrong eye situation. How do we prevent that? Good slit lamp skills. Ocular surface disease. Let's manage it before we send that to the surgeon. EBMD or ABMD. Do they need an SK or PTK? Irregular astigmatism. Identifying that with our tomographer, our topographer, or Ks. We don't want to make that recommendation if these things are occurring. The other stuff on the left is more in the surgical center's hands, making sure that the measurements are accurate, that the calculations are accurate, that the surgery is done beautifully and the IOL is placed in the correct spot. Those things matter, and that lens can rotate at times afterwards. So how do you determine if a lens is rotated and what you should do with it? Do you send it back to the surgeon? When do you send it back to the surgeon? So quite often, toric misalignment is something that ends up in our clinics, in the optometry's clinic. And the way that you can look at this is if you suspect that there's a rotation involved, it's good to talk to the surgeon and possibly get it back to them because they may want to rotate it back into position. There is a simple app out there you can download called Axis Assistant. I use this often with toric implants. And keep in mind that you'll have to get the records from the surgeon to know where that toric implant should have been lined up. If you look at the study I placed over here on the right, you can see that even a 10-degree rotation, you lose about 35% of the effectiveness of that toric implant. If it's 15 degrees off, it's 50%. And if it's 30 degrees off, they might as well just have a monofocal implant in their eye. So what you do with Axis Assistant is you dilate the patient's pupil, you find out where the axis is supposed to be of the implant. If we go back to these images here, you can see all these different implants here have these little marks on them. You can see three little dots up here. You can see three little dots here near the haptics. And so that's really what you're identifying when you're taking a look behind that slit lamp at that dilated pupil. You then line up your slit beam. So take your slit beam, you find where those marks are, and you need to twist your slit beam one way or another and line it up and down this way, whatever you need to do to line up where those three dots intersect. Once that's done, have the patient sit back. You take your phone, you have this particular app on your phone, and you put that where the patient's face was. You then focus and you can twist this instrument right here to different degrees. And you can get a perfect alignment of where that patient's IOL is lining up. And so, for example, if this patient was supposed to be at 90, that's what the surgeon said in their notes, and it's at 64, you can communicate that to the surgeon and say, this IOL is rotated significantly. It was supposed to be at 90, it's sitting at 64. It's behaving like a monofocal implant. Would you like me to send it back to you? If it's within a month or so, quite often in our clinic, we're bringing them back and we're going to rotate that particular implant. I know plenty that will still rotate within 3 months because fibrosis hasn't really happened. But again, easily identified in your clinic using Axis Assistant, dilating the pupil, finding the marks on the implant. Obviously, the other piece of the puzzle, if the surgeon doesn't want to rotate it, would be a laser fine tune. Quite often, patients are paying cash to have these types of toric implants, and so laser fine tunes quite often are included in those as well. Many of you have probably heard of monofocal plus types of IOLs. Here's three of them that are currently on the market. The way that I like to think about monofocal plus IOLs is they're going to provide you very nice distance vision. They're going to provide some intermediate, but they're really not going to provide near vision. And so when you compare these to a traditional monofocal is really providing no near whatsoever, really no intermediate as well. These monofocal plus types of lenses attempt to have a little bit of an EDOF effect to them without creating the glare and halos. And so I know there are practices around the country that are using monofocal pluses as really their traditional or standard lens, where every patient that comes in that chooses to do traditional cataract surgery is really getting one of these monofocal plus IOLs to provide good distance, to provide some intermediate, knowing that, hey, it's going to fall short at near, really not what it's designed for. Extended depth of focus lenses, a couple of these on the market that many of you are familiar with. These types of lenses provide good distance, very nice intermediate, and can provide some near vision as well. Not going to be as good of near vision as you'll get with a multifocal or these new trifocal types of technologies. Glare and halos, likely less, but can still be present. So I still educate around that. And really the advantage of these extended depth of focus is that they can be utilized at times with certain types of pathology. Let's say I see a patient that has a few gutata. It's not full-blown Fuchs dystrophy, but I'm a little bit worried about a diffractive IOL where light's going to get scattered or spread. But this patient is very motivated to not be in glasses all the time. These would be a consideration. A very small epiretinal membrane in the back of the eye that's very mild, not like the one we saw earlier. This may be an option I would consider for a patient like that because, again, it's not diffractive in technology. We're not splitting a bunch of light. We're just splitting a small amount of light with one of these technologies. The other one really is a non-diffractive technology. So some types of pathologies, these can be a great option. I don't promise a lot of near. I promise good distance, good intermediate, and a little bit of near. Probably going to need some reading glasses on hand at times. Then we get into multifocality. And the next generation of multifocal lenses have really been quite amazing, in my opinion. Again, the eye has to be healthy, okay? Regardless of the technology. If we have a dry eye, these technologies don't work. If we have Fuchs dystrophy, it's not going to work. If we have a problem on the retina, it's not going to be effective. But really, three different types of technologies here using multifocality where they're providing vision at distance, intermediate, and near. So more like trifocal technology. Each of these technologies does have their pros and their cons. I think the cons with all these technologies is when you talk about multifocals, you have to talk about glare and halos with patients. It's much less than it was 10 years ago with your traditional multifocals. but you have to talk about it. You have to mention it that glare and halos can be an issue. We measure things like high order aberrations. I'm much less likely now than ever before to care as much about high order aberrations because of how good these technologies that you're looking at have become. An example of this, in the last 4 years or so, I have sent more patients to have anterior vitrectomies after multifocal technology than ever before. And let me explain that a little more clearly. These patients come in, they have an eye that's set up beautifully for it. I've treated the dryness. We've done EAG capsulotomy to clear off their capsule. These patients are seen 2020, 2015. The retina's pristine, but they come in still complaining of some problems where, boy, I have this kind of fog, this kind of movement across my eyes. That didn't exist with old technology. That didn't exist with old multifocal technology. Why we see it with this is the vision and the way that the light gets through these is so good, and it's why we see 2020 and J1 in 2015, that even some vitreous syneresis can bother these patients. And I wouldn't say it's a common thing, but I never used to send a patient for a vitrectomy. Never. Now, I have a handful of patients that we've had to send. It's fixed them. They're thrilled to do an anterior vitrectomy because of how good these types of technologies get. So again, educate properly. What do I say to patients? I say, hey, you're going to be able to do 90% of the things you want to do in life with a technology like this if I'm doing my job, which is treating the ocular surface. We have a great surgery. We've ruled out any retinal complications. What are the things you're not going to be able to do? Well, if you like to sew and knit, it's going to be very challenging. Print on the back of this Purell bottle, so I'll grab that in my exam lane, or a medicine bottle, you're probably not going to be able to get. Tying a fishing lure, South Dakota, you're going up to Missouri to catch some walleyes. You might not be able to do that. And so I'm upfront about some of the things you're not going to be able to do. And if they tell me I want those things, then this probably isn't the technology for you. And so identifying that type of patient. But exciting technologies that have come into the market that have made us more and more confident when we make the recommendation around this. This is a small aperture lens, a technology that some of you may have heard of. It's really a pinhole effect. Years ago, some of you may have seen an inlay that went into the cornea. Very similar effect, except this is an intraocular lens. It's the only implant that can correct irregular astigmatism. So where is it being utilized? It's being utilized in certain post-refractive situations. In my clinic, where I've had a lot of luck with it, are in keratoconus patients that want some independence from glasses and contact lenses. This isn't a lens that's going to get that keratoconic patient to 20/20, but because of that pinhole effect, I'm able to give them really decent vision at distance, intermediate, and even bring a little bit of near into them because of the pinhole effect. And so moderate keratoconus patients do extremely well with this lens. Very mild keratoconus patients do very well with this. Advanced keratoconus, I'm much more careful with this. Those are patients, if it's very advanced, that I lean more towards saying, hey, probably a monofocal implant for you, and then you're going to need to be fit into some type of specialty contact lens or continuing wearing a specialty contact lens. But mild to moderate keratoconus, we'll do this bilaterally at times, and sometimes we do it unilaterally, but a great technology, only IOL that can correct irregular astigmatism, and it's really just the pinhole effect. So we'll go through a couple IOL recommendations now that we went through this, and then I'm going to go through kind of the psychology around this, and we'll end with a few cases. So as we look at this, think about what IOL you would recommend. I don't have the option of being able to have anyone talk to me through, the camera here. So I'm going to tell you what I would recommend, but think about it as I go through each case here. So let's go top left first. You have a 70-year-old retired engineer, likes to do model airplanes, reading iPad, has early open angle glaucoma, loves to take his glasses off to read, and he describes himself as stubborn. And so these type of patients, obviously very particular in what he wants to do. Look at that MRX, -2.25, -2. This is a patient where I'm going to be very, very careful on educating. I'm likely leaning away from doing a multifocal type of technology with this patient. So I would take that off the table for this patient. But I would talk to them about targeting for near with maybe a toric implant to correct the astigmatism if he has corneal astigmatism. If he has no corneal astigmatism and he's just wants to be at a minus 250, minus two and a quarter, we could do a monofocal technology targeted for near. That's probably the direction I lean with that first patient. We go to the upper right, 55-year-old farmer, likes to fish, watch TV, drive, doesn't wear any glasses, has some narrow angles. He's laid back, a hyperope. Love these types of patients. Laid back, number one, hyperope. If he wants to be independent or at least reduce dependent on glasses, this is a multifocal type of technology all day long for me, being 55, laid back, hyperopic situation. Bottom left, 80-year-old retired teacher, watching TV, reading, gardening, healthy eye exam, wears glasses, but doesn't like them. Age to me doesn't matter. If it's a patient that comes into me and says, hey, I hate my glasses, I would love, what are your options? Some patients will come in and say, hey, I'm 80. I don't know if I'm going to live another 10 years. They'll say that to me. They probably say that to you. I can appreciate that. And I'll say to them, if you don't want to spend X amount of dollars on these types of technologies, please don't do it. I'm not selling it to them. This was a patient that said, boy, I would love to have something where I don't have to wear my glasses as often. Not sure if I'm going to live another 5 years, 10 years. Maybe I'll live 20 years. Her choice, and I educated her on her options. I think this is a great patient being easygoing that I still would consider doing some type of multifocal technology. We can correct astigmatism with those technologies as well. Bottom right, 57-year-old pilot. Hobbies, has some early AMD. Glasses never seem to be quite right. So this patient's pretty particular. Hyperope. Hyperope, I said earlier, love multifocal technology, but there's some things that jump out at me here that would make me lean away from that type of technology. Being extremely particular, maybe a little early AMD scares me away a little bit. And just the fact that her glasses never seem to be right. And she's a pilot. Light adjustable lens technology, I would strongly consider it for this patient because we have the ability to adjust that technology. I would just educate her that reading you may need something for, but I'm pretty confident we can give you a really nice distance vision, really nice intermediate vision as well. And we have the adjustability piece to this. The psychology. Let's go around this a little bit because I think that for us as optometrists, we have patients that walk in all the time that have had certain types of technologies and they're unhappy, even when we think, boy, you should be happy. Why are you unhappy when you're seeing J2 and you're seeing, 20/20? And we want to understand why. And I think this was a great read from the Journal of Cataract and Refractive Surgery. And yes, it's older in 2009, but these are really the reasons why our patients walk in 20 unhappy. It's because of residual refractive error. Well, we're great at correcting this. We can do this we can do this with glasses. We can do this with contact lenses. We can do this with refractive procedures. Ocular surface disease. It can worsen after cataract surgery, and so we need to manage that. Could it be posterior capsular opacification? Take a look at the lens. Has that film started to form at 3 months, 6 months, or beyond? The hardest one, in my opinion, to treat are positive dysphotopsias. If these don't go away, the patient will sometimes see a moon or a crescent shape in their vision. That's a negative dysphotopsy, or they'll see a pinpoint piece of light, a positive dysphotopsy that they just can't get rid of. If that doesn't go away or they don't adapt to it, there's probably no way around that. We'll talk about problematic near points here in a little bit. And really the other thing we want to come up with is we want to identify the visually demanding patient and try to avoid that type of patient and putting in advanced technology in that. And you guys are masters at that. You have known the patient, you've seen the patient, they've been in your clinic for years and years to make sure that one of these technologies maybe doesn't get into that type A personality type of patient. So a couple cases. So cataract surgery is done on this multifocal implant in 2019 in the left and the right eye. On June 3rd, they're referred back to you, okay, for a YAG evaluation. Put yourself in the shoes of the surgeon or of the doctor in the surgical center. Patient complains of trouble with fluorescent lights, difficulty with night driving due to halos, and the vision doesn't seem right since after surgery. You can see their uncorrected vision is 20/50 in the right eye, 20/25 in the left eye. Best corrected acuity 20/30 and 20/25. This is a multifocal technology. I think 20/30, 20/25 is probably not good enough. But when you look at the PCO, it was about 2 plus, which 2 plus PCO does fit with that 20/30 vision and that 20/25 vision. So you look at that, you say 2 plus PCO, it fits with that. Should we YAG this patient? Should we remove that film? There is a key thing in the history that tells us that we need to take a step back and pause. When a patient says to you, the vision doesn't seem right since surgery, that concerns me. That means it's probably not the PCO. They've never been happy. Because when we think of posterior capsular opacification, it usually is going to form at 3 months, 6 months. It's not going to form at one day. It's not going to form at 1 week typically, or even 1 month. It's usually not there early on. If the patient said to me, boy, I loved my vision at week one, I loved my vision at month one, but boy, at about 3 months, it started to go downhill, or at about 6 months, it really started to go downhill, then I'm yagging that patient for sure. But if they've never been happy since surgery, I'm going to search for other things first. I'm going to overtreat the ocular surface. I'm going to make sure the retina is healthy. And if I've overtreated the ocular surface and treated it extensively, and I've looked at the retina and that looks great, then maybe I'll move forward with a YAG at that point in time. But you want to be careful not to assume always that the YAG is going to be the fix. Needs time. So this is just performing why you shouldn't. The brain will need time at times to adapt to these things. Not all patients will adapt. And we don't want to remove the option of an IOL exchange, which is uncommon, but at times it's definitely needed. So key part of this again, when did the vision seem right? At the time of surgery, it was never right, or it was really good for a few months. Here we have an EDOF patient. They come in for a 1 month check. Dominant eye is the right eye. They say, boy, my reading vision is not great. I have to wear readers. Not uncommon with EDOFs. You have to educate around this. But you look at their vision, you think of the extended depth of focus lenses that you've worked with. I'm pretty happy with what I'm seeing there. 20/20 in the right, 20/25 in the left. J5, J4. That's pretty decent reading with an EDOF lens. Lens is well centered. I don't see any capsular haze. So what do we do now? What do we tell this patient? We could tell them, hey, give it a little bit more time. What I like to do with these patients is I like to reinforce that they're getting some reading with this lens, reinforce that they made the right choice. And so I'll go to my trusty trial lens kit, the one I had gotten from optometry school, and I'll grab some -250 readers, and I'll go into the exam lane with the patient. I'll give them something to read. Usually it's their phone, something like that. I'll have them hold it and look at that. And I'll say, tell me how you're reading right now with the EDOF with nothing in front of it. They're like, well, it's not great. I don't love it as I told you. Then I pop the -250s in front of their eyes and I say, now what do you think? And they're like, I can't read anything. I pull that away and they can read again. And I say, I just want you to know that if we would have done a monofocal lens, this is how you would have read. And I put it back in there and I take it away. So it's just getting them to believe a little bit in the technology. And then it's a matter of just waiting it out, giving them some time. I'm going to see them back in 2 months, but not discounting their complaint. That's the last thing I want to do, is discount the complaints of these patients. Neural adaptation is a real thing. It could take 6 to 12 months when you look at the literature. And also 10% of the patients in the world that get an advanced IOL technology will not adapt to that technology. And so 4 big points around this. One, it may take some time. Educate your patients, talk to your patients, remind them that it may take some time to adapt to the technology. 2, it requires motivation. You don't want to be a salesman. That guy in the kayak, he's motivated. And so we want patients to be motivated. I view myself as an educator. I don't want to sell them the technology. It requires a belief. And the belief is really you as the doctor have to believe in the technology, number one, but take time to educate your staff. Your staff needs to believe in it as well. They spend more time with the patient than you do. And so they need to really believe in the technology so that they can educate patients when they're doing a pre-testing or they're working the patient up, that they've had experience with the technology, that they know it's been a positive experience. And then it requires support. I mentioned it earlier. Don't discount these patients' complaints. Just because they see 20/20 in both eyes and are reading J1, if they're complaining of something, I try not to discount that, because it could just be some mild ocular surface disease. Could be a little vitreous syneresis. It could be just a little bit of PCO, but supporting them. And our role is huge. And this equation kind of speaks to that. The satisfaction of our patients equals the results minus the expectations. And what this means is the results piece is the surgeon. So the surgeon is the results, and they typically do great cataract surgery. But if we don't set the proper expectation, then the satisfaction will suffer. And so we need to set proper expectations with these types of technologies. Some other things you may see on the market, A lot of surgeons are now using less drop type of technologies where they're injecting medication into the anterior chamber. Patients are now coming in with bottles of medication that are mixed. They may have an antibiotic, steroid in it as well, an NSAID. And so they're injecting some medication and then they're using a drop once a day, maybe twice a day. Some surgeons are doing just intracameral injection only and doing it that way to make it a better experience for our patients. Where is this all coming from? It's really coming from a couple different studies. This particular study looked at patients that received no antibiotic, patients that received just intracameral, patients that received just topical, and then patients that had a combination of the two, intracameral with topical. And you can see when it was combined, intracameral with topical, that was the lowest rate of endophthalmitis. Now, the rates are low anyways, but even one case of endophthalmitis is not fun in a clinic. So the lowest rate, as you saw in this study, was intracameral plus topical. When you look at the Kaiser study, another one, in 2007 in Kaiser, they were using only topical agents, no injections. You can see endophthalmitis rates in the blue were much higher than they were in 2011 when they started doing topical plus injections. Endophthalmitis rates dropped significantly. Injections and topical use increased. And so this is why you'll see surgeons or surgical centers now starting to use more intracameral injections, more combination type of agents. So I want to spend the last 4 minutes just covering a couple preoperative cases and then we'll wrap up. So this is a patient on day one coming in cataract surgery plus just cataract surgery plus an IOL. Complained of slightly blurry vision, 20/40 vision pinhole 20/25, but look at that pressure, 55. That's the danger zone. We see 55. That's really, really high. We can't allow that patient to leave our clinic without getting the pressure down. They're on their postoperative medications. This is what the eye looked like. So hot, steamy, inflamed, making sure we get this pressure down. Now, there's a variety of ways you can do this. Obviously, one way is you can throw the whole kitchen sink at them, all your topical glaucoma medications in the office, even an oral agent. But everyone on this call is very capable of burping a wound. And so I'm going to show you a video of how to do that. What I use is a sterile punctal dilator. You can see it right here. I put a little pressure on the small wound, the paracentesis wound. You don't want to burp the heavy or the large wound. And so give the patient a few drops of proparacaine. Initially, you may want to put some fluorescein stain in the eye. And then all you're doing, you don't have to go inside the eye, is just putting a little pressure on the outside of the wound. And this is typically done at day one only. And so a little pressure on the outside of the wound, you're going to burp that. Sometimes you'll have some thick viscoelastic that'll come out. Just burp that wound down to the mid 20s, low 20s. We don't want to take them all the way down to 0, 1, or 5, just because you can cause a decompression type of retinopathy. Another case, this was a 1-day visit. Patient comes in, slightly blurred vision, and you see a pressure of 3. What are our considerations here when the pressure is that low after standard cataract surgery? The eye looks like this. There's some central corneal edema, not uncommon. But the next thing that you have to do is you need to paint the wound. And this is what you see after you paint the wound with some fluorescein. This is a Seidel positive situation. Do we need to rush this back to the surgeon? No. Every one of you is very capable of managing this. First step for me, place a bandage contact lens on this. I'm going to try to seal that up as best as possible. This is day one. I'm going to have them continue their antibiotics, continue their post-operative drop, and then typically I'm going to see them back a few days later to see if their pressure has now stabilized or gotten better. If the anterior chamber would have been flat, where the iris was touching the cornea, that is a situation where I would send it back to the surgeon. If the anterior chamber is well formed like this patient, there is some debate in the literature on whether or not we should stop the corticosteroid drop. Reason being is corticosteroid drop could shut down the ciliary body. It can lower the pressure even more if it's early on in the postoperative period. My belief is I just keep them on their antibiotic. I give them a bandage contact lens. I put that on, and I give them an eye shield so they don't rub their eye at night. And then usually I'll see them back a few days later. If by 1 week the wound is not healed, then I will definitely send this back to the surgeon. Last case here. This was a 10-week cataract postoperative check. Patient had blurry central vision in the right eye. At 10 weeks, I would not expect best corrected vision of 20/50. They did have some PCO. And then just kind of taking a quick look at the fundus, I kind of saw this faint yellow spot in the fovea. This is really what the posterior exam looked like. I know you don't have stereopsis here. So all of us would order what we should here. Let's get an OCT. And that's what you see on the OCT. So we know now that we're dealing with cystoid macular edema, something that commonly can occur around 3 months post surgery, sometimes as early as 2 months, even out to 6 months. And how do we manage this patient? Be aggressive. 4 times a day corticosteroid, twice a day, typically NSAID. So even the once a day NSAIDs, I'll typically dose twice a day. So I usually do 4 times a day corticosteroid, twice a day NSAID. I see these patients back 2 weeks later. We should be seeing improvement at 2 weeks. Then I see them again 2 weeks later in a month. If by a month it's not resolving, then I have something else in my mind. Is it a small branch retinal vein occlusion? Am I missing something else in the eye? Because really, with that aggressiveness of treatment, 4 times a day steroid, twice a day NSAID, we should see significant improvement of this type of situation. So, in conclusion, artificial or advanced IOLs, they do give excellent results as long as these patients have a healthy eye. Be aggressive with the ocular surface, treat it before you send. And we want to insert these in healthy eyes. We don't want to put these in eyes that are unhealthy. And we want to set proper expectations. Many of you are going to manage postoperative surprises, but you're all capable of it. And the most common ones are the ones that we looked at today. Approach residual refractive area in a methodical fashion. Toric lenses, make sure you take a look at those. And talking to your patients about these technologies can be very rewarding. You can take patients that were very unhappy and make them extremely happy, and they'll continue to be your patients for the rest of your life. Thank you.
Awesome. Thank you so much. We have a lot of questions in the chat and the Q&A, so I tried to consolidate as many of the ones that were similar as possible. A few questions were asking about if you ever mix lens designs and how often you would do that, such as a multifocal in one eye and an EDOF in the other.
I used to do it a lot, and there's still good studies out there showing that mixture between certain multifocals and EDOFs. I really think with the next generation multifocals, the three that I showed you there, in my opinion, that ship has sailed a bit. I'm not saying it's wrong to do that by any means, because I'm sure there's a lot of happy patients. But if they have a healthy eye and we've treated the surface, these new generation multifocals really are giving patients great distance, great intermediate, and great near vision. You still have to talk to them about glare and halos. It's still part of it. But I've kind of gone away from mixing and matching and really gone to go into those advanced new types of multifocals.
And do you have a go-to multifocal for patients that are high myopes?
Used all of them in high myopes. I would tell you advantages, disadvantages. So when we look at those three, speaking of, let's say, in my experience, Panoptics, for example, has been a great distance lens, does a great job intermediate, does a really nice job at near. But if I have a patient that demands a lot of near vision, they're very near demanding, that's more of a type of Odyssey type of lens. That was the other one you saw on there. That lens seems to perform very well at near, maybe not quite as good at distance, or Panoptics performs a little better at distance, maybe not at quite at near. And we're nitpicking here. I'm just giving you examples. And then even the other lens from Zeiss, the Envy lens, or the Envy lens, a great distance lens, probably performs a little better at distance than it does at near when we compare those. So I think any of the three are reasonable for a high myope. What I will say,
Great.
though, I will comment on this. You have to be careful with myopes, especially ones that take their glasses off to read. And I always tell them, hey, this multifocal technology may not be as good as what your natural lens was when you were 45 or even 50, and your prescription, you were taking your glasses off to read. This technology may not be as good, so you need to be aware of that.
Hmm. Definitely. Yeah, I love all of your tips on patient education, and that's pretty wild that it can take that long for neuroadaptation in some of these multifocals. There were quite a few questions on the small aperture lens.
Mhm.
Are there any concerns with visual field complaints, low light issues for the patient seeing out? And then how about with the doctor looking in, any concerns with like a fundus exam?
Yeah, great question. No, it's actually really nice. It's almost like a mask. It's kind of in a way clear. It's kind of a clear mask. Now, When you do a YAG capsulotomy, you can't shoot through the mask, you'll wreck the lens. So that's one nuance. If you're a doctor doing YAGs, that is one I would not do your first YAG on. I would become very good and proficient and probably even be taught how to do it on that. One tip on that. But you can do a fundus exam. You can see right through it actually very easily. Um, and then no issues really with low light because that mask is actually a bit translucent. The light can travel kind of through it to a degree. You'll be able to see it, but it's still you're functional. You're able to dilate. You're able to see everything.
All right. And then last question that we'll have time for tonight is for these patients that we're co-managing and they're unhappy with their results, at what point do you typically want them to see the surgeon again?
I think that if I have managed their ocular surface to the best of my ability, I've ruled out retinal pathology, and we've said, hey, let's say the posterior capsule's clear, or say they had a YAG and they're back in your chair again and they're still unhappy. Neural adaptation can take 6 to 12 months. So, not that I like to string my patients along for 6 to 12 months, but I educate them that I would like to at least get out to a year if I can, unless the result is just horrendous. But usually, if you can treat the ocular surface, retina's okay, YAG capsulotomy's done, or you're sitting on the egg capsulotomy because you don't think it's the right thing to do yet, as that patient we talked about earlier, I will work with them for 6 to 12 months because neural adaptation, and that's based on the literature, can take that long with some of these technologies.